So hello and welcome everyone to our nutrition forum. We are so glad that you're all here to join us. And we do have quite a few very impactful ministries or work being done in Haiti that they're here to share with us what they're doing. So we're excited for that. But before we get to that, I would like to just do a little overview of what the current situation is in Haiti. And I'm sure many of you are more than familiar with this, but just to make sure we're all on the same board here, we'll just go through what the current situation.
There's coffee.
Oops. So many of you have probably seen this report. It's the IPC, stands for Integrated Food Insecurity Phase Classification, and Haiti has continued to fall deeper and deeper into the emergency phase from crisis. And as you can see from this, actually, I'll just skip ahead to my next slide. It's a closer up here. Much of the country is now currently in crisis mode, and quite a few also in emergency, which is a very serious situation, especially given the current instability in the country, where even getting in food and humanitarian aid has become near impossible in certain situations. So you can see here just the breakdown of the percentages. This is 9.9 million people were included in this number here out of Haiti. So 24% are in the minimal impact phase here, 28% in stressed, 29% are currently in crisis, which as you read through this is quite serious. There's food consumption gaps with high or above usual acute malnutrition, with 18% in emergency phase and 0.2% in famine. So the impact on this on health is incredible. So we had one of the members of the Haiti Health Network actually went through and did this calculation using this information, and has estimated that 562 Haitians are dying every single day from hunger, which is a staggering amount. And when we first saw this, it was very shocking. I mean, I think we all knew and understood how serious the situation is, but to see the actual number of 562 every single day it's unacceptable, and it's completely shocking. And this is one of the reasons that we're here today. We in our Haiti Health Network meetings are constantly hearing about the struggles that we are all going through to continue our work in Haiti. And one of the things that keeps coming up is how malnutrition rates are increasing and increasing. And so we've put together this forum so we can learn from each other, learn from those who are already doing the work, and talk about some possible solutions together. And so we do have Rasha, Lindsay, and Amy are here, who work for 3 different organizations that are all doing malnutrition or nutrition programs, and in different ways. So it'll be interesting to see the different programs that they are working with. And I also have some information. So I'll be presenting on behalf of Real Hope for Haiti, who has an extensive program as well. So they'll be included in this also. So we've actually prepared our presenters with some questions so we can all know what we're talking about here. And then we also have Chris from Meds and Food for Kids, who at the end of this part of the presentation will be sharing what they're doing in Haiti to help fight malnutrition and to bring nutrition out. And then we're going to open the floor to anyone who has questions, comments, wants to ask any of our presenters, or really anyone else on the call. This is an open discussion forum, so we're just we'll do some presenting, and then you will have the chance to ask questions. So while the presenters are speaking, if you have any questions that do come up, just jot them down. We'll have ample time at the end to go through that. So first, I'm going to ask Lindsay to speak first. So Lindsay is a nurse. She has worked in multiple leadership roles at Dunedin's Children, which is in northern Haiti, for the past 6 years. She was the administrative director for 4 years and is now the director of the NICU and the surgical department, as well as assisting with the nursing staff. She has a bachelor's degree in social work as well as a bachelor's degree in nursing, and has been a nurse for over 10 years. Lindsay has been coming to Haiti for 15 years and has helped in many different departments all across the country, but calls Wanamith home. And so, Lindsay, I'll pass it over to you. I do have some slides for Lindsay here, and then we're going to ask the question of what your current program is and what changes these programs have seen in the last 5 years. So we'll start with Lindsay, and then we'll go to our other presenters. Go ahead, Lindsay.
Thanks so much for having us. I also want to introduce, I invited a couple of our nurses to come with because I actually personally am not overseeing our malnutrition program, but we have our lead nurse, Ann Rose, who actually runs all of our outpatient malnutrition program with us. So I might translate some things or if we have questions for her, but she's been doing a malnutrition program for more than 10 years. And then I have another nurse with us here. Her name is Shelly, and she's one of our inpatient nurses and emergency room nurses that also helps with our malnutrition program. So I just thought it was really essential to have those with us. So even though it's in English, we'll be able to translate and just learn about other programs as well. So our program here at Dunedin's Children, we actually are one facility that is a clinic, an outpatient clinic, and also an inpatient hospital. So we have an outpatient malnutrition program that has about 75 to 80 patients in it. So there's a lot that goes into it. So I'm going to try to keep it as brief as possible. You can pull up the slides, Rachel, and I'll just kind of show, but there's different levels of programs. So as the child comes into our facility, every single child gets evaluated for malnutrition, and there's a lot of ways to do that, but the main thing that you need to do is height, weight, and then you also do this measurement that goes actually on your arm, around your arm, which will show the degree of malnutrition. So depending on where that falls, would then put them into 3 different programs that we have available. One is, so you can see this obviously is not in English, but just evaluating the child and then going through and depending on what program they go into. So you can go to the next slide. So PTA, our PTA program, there's a lot of requirements. So I think sometimes there's a misconception too that, you know, the malnutrition programs, a lot of people, I know MFK is going to talk about Pumping Nut, but that you can just hand out Pumping Nut and, you know, that's it. But it's actually very regulated. We are actually regulated by MSPP as well. So there's a lot of guidelines that go into if a child actually is required to go into a malnutrition program. So the PTA is for moderate malnutrition, moderate with complications, or severe malnutrition without any complications. And then PNS is also malnutrition that's kind of in between mild and moderate. So it's kind of more of like a step down, if you would say. So PNS would be the lowest amount of malnutrition that we would admit, and then we would go to PTA, and then we also have an inpatient malnutrition program, which is called the USN. So as far as like the USN program, it's inpatient. It's a lot more in depth. My understanding in the north, and anybody on the call obviously can correct me, there are not a lot of inpatient facilities that actually take inpatient severe malnourished children. So there's also a protocol for if they get admitted for that. So a lot of times when they're considered to be severely malnourished, they're going to have some sort of complication that could go with that. That could be pneumonia, that could be multi-organ failure, kidney failure, respiratory problems, kidney failure, all those things that merit to be hospitalized on top of, you know, their malnutrition. So in the inpatient, we can go to the next slide, I think. Going back to the outpatient program, what the outpatient program does is it depends on what program you're in. One, you come every 8 days or you come every 15 days. And we actually do give this, which is Medica Mumba. So it's a therapeutic peanut butter, which MSK will talk a lot more about. This is actually given to the child depending on where they fall on the scale. So you're going to do their weight and their height, and then that's going to tell you how much of the therapeutic peanut butter that you're going to give them. But we also actually in our program are able to give out some outpatient medications depending on what's going on. This is completely run by our nurse, but since our program is inside of our hospital, it's also overseen by our physicians as well. So if she sees any complications or anything's outside of her scope of practice, she's going to go to the physician to help guide her. But this just shows that there is a protocol for medications that she can give, because a lot of times, obviously, kids that are coming in, they're going to have skin problems, they're going to have a little bit of respiratory problems. So she has the liberty to be able to give out some medications depending on what's going on. So you can go to the next slide. This shows her protocol for her weight and her height. There's actually one for male and one for female. So when she actually registers all the information of the child on this chart, it's going to actually show her how much Medica Mumba to give and also what category she falls. So it just helps her know how to follow the protocol correctly and then what to do with the child. Next slide. This actually shows, depending on their weight, how much Medica Mumba is required per day or per week. Next slide. Then I just wanted to show there is a lot of documentation that goes with. There's an admission form, and then there's a weekly documentation that they do with each child. Next slide, which is the next slide, I think. Okay, and so like I said, we have 2 outpatient programs, and then we have our inpatient, which is the USN. And in the inpatient, we actually treat malnutrition with therapeutic milk called F75 and F100, and then also with the Medica Mumba as well. There's a lot of details that go with it, like who is actually able to receive the F75, what is it for? There's different phases as well. So you start with F75 and then you go to F100 and then you go to Medica Mumba and so on, as well as treating whatever other complication they have. So it's very complex, but we're really thankful, that we have such a great program that intertwines with each other. So our outpatient and our inpatient are in the same facility. So just if you're in the outpatient program and you're getting worse or you're not able to get better with the treatment, they can be admitted into the inpatient and vice versa. So when our patients get discharged from the inpatient malnutrition program, they can then be put in the outpatient. So there is some continuity of care, which I think helps in the long-term recovery of malnutrition. So that's basically what we do at Danita's. Again, there's like a lot of information that goes in it, but that's our malnutrition program.
Thank you so much, Lindsay. Sounds like a really amazing program you have there. I'm going to ask next Amy if she can share with us, and I know she does have some slides. So Amy is one of the founders of Second Mile Haiti, who's also working in northern Haiti, in Haiti right now as well. She's been there since 2011 and is serving as the organization's program director. So I'll hand it over to you, Amy, and look forward to learning from you as well. If you would share with us your current program and any changes that you've observed over the past 5 years.
Okay, let's see if I can share my screen.
Yep.
See if I present. Okay. Are you all seeing? Well, I'll just share the whole screen. Okay, so yes, my name is Amy. I'm an RN as well, and I'm happy to be here, happy to see all of your faces. I'll start by saying just a little bit about Second Mile Haiti. We've been doing malnutrition programs since 2013. We currently operate 2 inpatient well, sorry, I shouldn't use the word inpatient. They're semi-residential treatment centers. One is serving Greater Northern Haiti. It's located in Cap-Haitian. And the other is in San Rafael, which is also in the Northern Department, but it catches more people from the Central Plateau and families there. And
Amy, sorry, I'm just going to interrupt you. We're seeing, it says presenter window on the screen that you're sharing.
oh, okay, let me see if I can. Where is Zoom? I click on this. But let me stop my share and try this one more time.
No problem.
Okay. And let me just hit present and are you still seeing presenter window?
If you go to the,
Yes, please help me. I don't know how to do
if you go to the bottom right of that first slide there, where a little bar pops up, or no, the top preview slide, sorry. So where it says unique approach, in that
Yes.
larger, yeah, the bottom.
Oh, the arrows there?
That, yeah, there's 2 arrows that are going diagonally right
Yep.
there.
There we go. Oh, we can still see your notes, but I think that's okay.
It's,
Okay.
yeah.
Okay. Yeah, no problem. Okay, so yeah, better that at least I can see my notes. Okay, great. So yes, I mentioned we have the 2 centers now, and the total between the 2 centers, we have 42 beds. Families spend an average of 8 weeks in our program. Colleges, social workers, health educators, and children and their caregivers stay Monday through Friday. So our goal with this approach, and I'll tell you a little bit of why we opted for this type of setting in a minute, but our goal is to be able to meet the immediate needs of the children with severe acute malnutrition, but also to have a way to really invest in caregivers with business opportunities and health education in the hopes of preventing relapse and hopefully preventing future other children in that same family from having to experience severe acute malnutrition as well. So yeah, now our decision to go with this approach, so we have our facility where we have each malnutrition treatment center has 20 beds. One has 20 beds, one has 22 beds, and we have all of our programs right there on that facility with gardening classes and health education classes, and our entire team there supporting the families. And we're able to refer to the hospital as needed and get kids to and from the hospital who need it. Now, we opted for this approach just because when you're looking at barriers to recovery with an outpatient setting, we know how hard it is for families to get to and from the clinic every week. And we also know that you're also prone to see some ration sharing where you give out the plumpy nut and the family, because of their resources, have to share that ration with the other children or the entire family. And sometimes it can take longer to identify underlying illnesses that can just delay recovery. In inpatient settings, it's just really extremely expensive for family members. And you might see kids who are lost to care or end up having to leave the hospital before they recover, just because of low health literacy and also the family not having funds to pay for food in addition to medical fees. So at our center, we do take children with severe acute malnutrition, like Lindsay explained so very well and showed us the armband. So that's either with the nutritional edema, that small middle upper arm circumference, or the weight for height chart that Lindsay already shared. She shared this graph too, so I can just skip right through, but I really appreciate Lindsay you talking about all of the reasons why a child would need to be referred to a USN. So 6 out of the 10 children that we see arriving at our center do meet that criteria. Either they fail an appetite test, which is essentially eating a certain amount of the plumpy nut based on their weight in a certain amount of time, or they are just really low on that chart Lindsay showed, or maybe they have one of those complications she mentioned, severe dehydration, abnormal vital signs, or that they just don't fall into the age bracket for outpatient treatment, which would be between the ages of 6 months and 5 years. So yeah, 61% of our children, we accompany them to the hospital so that they can get a full workup and get their parents used to the hospital setting. And then 22% of all of the kids that we see do require a hospitalization. And the average stay is about 12 days where they're getting potentially IV oxygen, deeper diagnostic testing, and often blood transfusions. So that would be 12 days at the hospital, but before then coming to our center and spending 8 weeks with us Monday through Friday. So just quickly on the changes that we've seen, one thing that we're able to really have a close look at is what other underlying conditions children with severe acute malnutrition often present with. 12% of the children that we've admitted to our centers had either tuberculosis, a neurological disorder, HIV, hydrocephalus, a heart condition, or sickle cell anemia, which having one of these conditions of course, increases their risk of mortality and also failure to respond to treatment. And we also see the treatment length averages much longer than that 8-week average. But most interesting for us has really been the changes in the number of children with HIV and severe acute malnutrition at our centers. You see in 2017, we're up above 6% with a nice steady decline, and then trending up again between 2022 and 2023. I think one of the explanations for this could be that here in Northern Haiti, and I'm not sure about other places, I hope this isn't the truth for the entire country, but there hasn't been as much routine prenatal testing for HIV. So you're not able to get that early diagnosis and prevent mother-to-child transmission. So I think, unfortunately, just due to a lack of testing supplies over the last few years, we are going to be seeing more HIV accompanying severe acute malnutrition in this year and potentially the next couple of years. This last slide about these changes over the last couple of years that I wanted to share is just the rate of children who are referred. So I mentioned that 6 out of 10 meet that requirement to be referred and at least screened at a USN or a hospital. Now, in 2018, more than 30% of those children were given a bed and stayed at the hospital for some length of time. Here in 2023, we're seeing less than 10% of children are subsequently admitted. And I just think it's a real reflection of just the general overwhelm of the Haitian health structure at this point. There just aren't enough beds to meet the needs for all the children that would require hospitalization at this point in time. So that's my share for this portion. I'll stop my share.
Thank you so much, Amy. I have to say your slides are beautiful. I do appreciate that. I'm going to ask Rasha if she can share with us next. Rasha is also in Northern Haiti. And after studying nutritional science and international development at McGill University, Rasha worked on various nutrition projects in the Philippines and in Burkina Faso. And I'm not sure if I'm pronouncing that right, so please correct me if I'm wrong. But for the past 9 years, she's been living and working in northern Haiti. For the first 2 years in Haiti, she did work in the nutritional department of Meds and Food for Kids, who are going to be presenting later for us. And she's now the managing director for Care to Communities, or C2C, which is operating 7 clinics in Haiti. So Rasha, I invite you to share with us about your program and the changes that you've seen in the last few years. And your background is beautiful. Look at that.
Thank you, Rachel. So C2C, the 7 clinics are affiliated with the Ministry of Health, so the MSPP. So we have a PPP model, private-public partnership. So for us, different than what Lindsay and Amy shared is that we go about outpatients. So kids come on a weekly basis, they get their mamba, they get weighed by our community health team. So right now it's our community health team that manages it in all the clinics. And there's a nurse and there's a community health worker together that see on a weekly basis the kids. Where do we screen the kids? We go when we go vaccination on the field. So we have vaccination on the field every week. We have once a week on the field and once a week in the clinic. So we go on the field to vaccinate all the kids that can't reach our clinics. Then we do screening for malnutrition. And as they did the mid-arm circumference and the weight and so forth. And then we, if they look like they're malnourished, then we send them with a coupon to our clinics so they can get a better screening. Back in the days, we used to get funding from different organizations to help with the program because of transportation fees. So a lot of the kids kind of drop out and stop coming to the program. So that's like the biggest factor of having a great program, is because with the transportation fee, we work in rural areas. It's very far to come on a weekly basis. And most of the kids that we treat are moderate. So there's a big dropout, but back in the days, we used to give a small stipend for transport to help them out to come on a weekly basis. Right now, we don't offer that anymore, but we are still looking for funding. Eventually, we have a new development program manager that's gonna work on that. But I think if we give a stipend, if anyone wants to start a malnutrition program, I think and you want to do an outpatient one, I think transportation is something that you should discuss, because that's the biggest factor influencing the dropouts. We mostly have moderate children that are in our programs. The severe one, I don't think we are adequate enough to treat them, so we refer them to Second Mile. And they're such delicate state, and as Amy mentioned, they might have other diseases on top of malnutrition. So best to be put in an inpatient program. How do we get to work with the MSPP? So the MSPP provides us the Mamba for free. We fill out monthly reports to them. We have, as Lindsay said, a paper for each patient, for each child that gets into the program. We provide a report to the MSPP, and depending on how many kids are enrolled in the program, we get the amount of Mamba from the Ministry of Health. There is shortage. There will be always shortage in Haiti, and we have resorted sometimes of buying it from MFK just because we don't want to stop the program. But in general, the government can always provide in general for us, because I don't think we have as big quantities as Lindsay in our programs or Amy. And I think that's about it. Yeah, I think I'll end it there.
Thank you so much, Rasha. That's really great. I'm going to go back to sharing my screen here. And sorry. Okay, so I'm going to be presenting on behalf of Real Hope for Haiti. Same questions as the other organizations. And Lori is on the call. If there are any additional questions, feel free to put them in the chat for her. But she provided some incredible information on their program. They are in Kazal, which is in the West Department, and their catchment area is the Cabaret and Akaye communes, which some of you may know that this area has been under a lot of gang attack, especially in the last few days, unfortunately. So we'll just move forward with this. And thank you so much, Lori, for preparing this in the midst of everything that you've all been going through. So for their programs, they have the same, these are the same like PTA, PNS, and USN, which I was unfamiliar with before working on this. And when everyone else was bringing in their slides, I thought, oh, these are the titles that everyone is using for this. So they do also have an inpatient clinic. So they treat the severe malnutrition with complications inpatient. They average 45 children, and they do have a max of 50 inpatient beds. And they use the F75, F100, Medica Mamba, and AK 1000, which have been mentioned already. They also have their severe malnutrition outpatient program. So this is treating severe malnutrition without complications. They have approximately 15 kids, or averaging 15 kids, and they have weekly visits with these children using the Medica Mamba based on the weights of the children. And then they also have the moderate outpatient program, the PNS. So this one has quite a few children, and also pregnant and breastfeeding women who have monthly visits, so averaging 140 children. And again, they're using the Medica Mamba, and they're also currently using the AK 1000. I hope I'm saying that correctly. Prefer to use the Medica Mamba, but as things are sometimes difficult to get, as we will discover a little later on some of the reasons for that, which I'm sure many of you are familiar with, you'll see why. So they do use this screening tool. This is one that's in English, and very similar to what's already been shared, the arm circumference. So when the child comes in, they are screening. Every child that comes in is screened, and their reporting is done on everyone who is 5 and under, which is part of the MSPP protocol. So depending on arm circumference, you just go along this easy to use chart. And one thing I just want to point out is I really love on here where it talks about encouraging the family, and where does it even say that? There's lots of education and counseling for caregivers, doing education, and you can easily follow along with this screening tool. So this is something we are able to share after the webinar for anyone who is interested as well. Now, they in their clinic have, they keep incredible data and provided a lot of these great slides. So you'll see here, these are children who are the SD rating of 3 or -3 and 4. So these would be the severe malnutrition. And you can see this is from January 2019. And you can see here that level 3s are shooting right up currently. Unfortunately, there has been a downturn a little bit here of the level 4s. They do also have other programs. They have an infant formula program. They have approximately 10 or average of 10 infants. And they also do education and support for caregivers in that, which is so vitally important. And then they also have a food boxes program where kids can graduate from one program to the other to really get a full continuum of care. So this is the program in Kazal. And thank you, Lori, for providing that awesome information. So our next question, oh, sorry. Supply chain issues. How has this impacted care, and what other barriers are impacting care? Supply chain is a major issue right now in Haiti, as I'm sure all of you are more than familiar with. So let's start with, I'll start with Lindsay again, if you want to answer that one first, and then we'll have everyone else share as well. So supply chain issues and other barriers that are having a real impact on your care.
Yeah, well, I mean, supply chain just in general in Haiti, I think is very difficult, depending on the circumstances and what's going on. And so, for us, it really just depends because like some of the other programs said, we do get supplement of our Medica Mamba from MSPP, but they don't always have the supply that we need since we have a large amount of children that are on our program. We have about 80 in our outpatient, and then we have an 18-bed inpatient facility. So we actually then have to purchase on our own from MFK. And even there's been times with MFK too, depending on what they have going on. I know the fuel is a big issue and things like that, which I'm sure MFK can talk about that sometimes depending on their supply as well. So obviously that affects our program, but I feel like when those things do come up, we really communicate really well. Or if we know in advance, I know that MFK is really good at saying in advance if something does come up, that we're able to either give more to our patients and then have them come back when we do have the supply. But for us, since we're a private facility, we have the resources to be able to purchase that. So I think that allows us to not stop our program. Like Rasha was saying, is even though we get some things from MSPP, it doesn't stop our program if MSPP doesn't have it. But I think the other things that have affected obviously is the price of everything. I mean, malnutrition is so complex because it's not just about food, right? Like Rasha talked about transportation and getting to the hospital and things like that. So you're everything the cost. So cost of taxis, cost of medications, that obviously affects and challenges malnutrition and the support that we can give sometimes to these parents. But I did want to mention for our program is completely free. So our outpatient program is completely free. Obviously, Mamba is free. Our medications that we give out to our malnutrition patients are free. And then also for our inpatients as well, because as you know, if someone is in this state of malnutrition, they don't have the resources to provide proper nutrition and food and resources. So how are they going to be able to afford coming to the hospital and getting the care that they need? So that's something that we built into our budget and our program, is to be able to provide that care for them, whether it's inpatient or outpatient. I know sometimes public hospitals don't always have those resources. So then what happens is they end up referring them to us, and then we'll take on their patients if we need to, if they don't have the resources. But with malnutrition, it's not just a one-time thing and done. So I think everybody has to refer to look at where they live and try to find a malnutrition program that is in that area, because it's not effective or realistic to have a mom that lives 2 hours away having to come every single week to come in. So yeah, I mean, supply chains, you have to become creative and resourceful and continue to stay positive because there are challenges in Haiti. But I think that if you have a very well-run program, you can try to anticipate those problems and then find solutions when you're having those problems. So those are the barriers and how it affects us and others.
Thank you so much, Lindsay. I'll pass it on to you now, Rasha, if you want to share some of your barriers to care or supply chain issues that you've had.
I think I listed them and Lindsay added, so I don't have much more to add other than transport, the biggest barrier. And as she said, if the program never really stops, because if the MSPP can give us, then we have budgeted in our budget for Mamba to be bought from MFK. So I think those are the two biggest barriers.
Thank you, Rasha. And what about you, Amy? Oh, I can't see if Amy is.
Hi.
There we go.
Back. Here we go. Okay. Yes. So one of the main barriers we've seen recently, or I should say, let me start with the supply chain. One of the main supply chain issues that has really come up with the children that we refer to the hospital and then we pay for their services and accompany them through that hospitalization until they can come back to our center for the rest of their rehabilitation. And there's really not a consistent supply of blood at area hospitals, and that it's common for a child with severe acute malnutrition to need a blood transfusion for severe anemia. At least it has been in our population. Sometimes you can get it from the Dominican Republic via Wanamit, where Lindsay is located, but it's $210 for a single pouch of 450 cc's of blood. So we really tried to investigate that this past year, and even did a blood transfusion with one of these centers. But the issues they were sharing are that transfusion supplies aren't coming consistently from Port-au-Prince, and donation collection supplies aren't coming consistently. So you might have willing donors, but no supplies to be able to collect the blood, or you have the blood, but you haven't gotten the test results back from Port-au-Prince, so you can't give it to the people who need it. So that's just one of the interesting, kind of unfortunate problems we're seeing. Another barrier, I guess the biggest barrier for us personally, is capacity. We only have these 42 beds, and the need is much greater than that. So we have tried recently, we recently started an outpatient trial. We do kids to the hospital first, so we can feel confident sending them back to their home for that evaluated. And then we see them in the same way that these other PTA programs are operating, where we see them once every 2 weeks to give them the RUTF. But we do pair that with a cash transfer, an unconditional cash transfer, so that we can know that the families are eating, the caregivers are getting enough to eat, and the families are adequately nourished, so that we know that that RUTF can be used for the child to recover. It's going pretty well so far, and we may be open to trying to implement being kind of the program support partner in other facilities that may want to do this, a PTA program with the unconditional cash transfer. So we'll see. But like Lindsay said, we do get hospitals who, because families can't afford that inpatient care, they send them to us as an organization that does have resources. And because our center is just semi-residential, it's not officially inpatient, we're then sending them back to our local referral hospital, which, as I mentioned, is already very overwhelmed. So yes, just another point that malnutrition is everywhere, and it's pretty overwhelming right now.
Mm-hmm. It's so good to note too that you can't just deal with the child who's malnourished, but also having to deal with supporting the family, as you're saying as well, is so important. I'm going to go through our answers here from Casal, which is closer to Port-au-Prince here, just because I feel like some of their issues are slightly different than those who are up in the north. Thankfully, things are a little bit easier there, not that it's not all connected with supply chain and all of that too. So this is back with Real Hope for Haiti in Casal. So some of the supply chain breakdown impacts that they've experienced, a lack of eggs and chicken. So they're now purchasing and using more beef, goat, and beans for protein. Limited access to typical routes. So they're forced to use boats to transport from Port-au-Prince and donkeys to transport from over the mountains. So this is one of those workarounds where the typical road, you can't just drive to Port-au-Prince, and they've gotten very creative in getting supplies still to their location, although it's not always a safe route, even when you're going on the water. And I know that they did recently bring back some supplies from meds and food for kids on the donkeys. So they're still getting the work done. limited availability of food staples for extended periods of time, which then of course impacts the quality and variety of nutrition available in the area, which ultimately will impact the nutrition that these children are getting. And then of course, inflation, everyone is feeling this one. When it comes to purchasing supplies, this is an ongoing issue. Many programs have been able to sustain, but the longevity of how long they'll be able to do that is in question for many, many organizations. So other barriers to care that they are experiencing is that patients don't feel safe to come to the clinic, so they're delaying care. And this is something we hear about constantly in our roundtable meetings, that people are coming when they're far too ill and sort of missing that window where they can get the care that they really need. Displaced individuals, so people are migrating within the country to get away from the more gang-held territories. And this leads to accidents, injuries, and uncertainty of food and shelter. Trauma is huge. We all know this, the impact that that has on health, overall health, sexual assault, and all of these things. And there's limited access to care that they need to recover from those things. Communication difficulties with phones going down. Fuel scarcity has shut down hospitals. We all know this a few months ago. With so many medical facilities closed in the areas, they can't refer when a patient is beyond what they're capable of. There's nowhere to send patients, which is a devastating situation to be in. And the list goes on and on. Unsafe transportation. We talked about the blood scarcity already. Staff shortages, the brain drain that's happening right now with people fleeing the country. Decreased level of care. Parents and caregivers die or are displaced, leaving the country, and often children may be left in the care of others, and it just perpetuates the problem. And of course, everyone is living in survival mode. The closer you get to these gang-held areas, it's just survival right now. And so this is affecting people as well. And staff morale, of course, is suffering. So there is so much happening, so many barriers to care at this point. Another topic we wanted to touch on, we'll just do this briefly as we're already getting close to the end here, and we definitely want to hear from Meds and Food for Kids. So I'll just go through the slides that I have, but Amy, I'm not sure if you have something you want to share on this too. I'll give everyone a chance if there's something that's not covered to feel free to jump in after. But we'll just cover some of the data that's collected here. So it's been mentioned for MSPP, there's a lot of reporting that has to be done. And what they're doing in Casal is, charts for everyone, doing questionnaires, making sure they have all of the information for MSPP, which is where some of these excellent graphs are coming from. Some of the major changes that they're seeing while they're measuring all of this data, and I found this one very interesting, is that there's an increased request for birth control, unfortunately increased malnutrition, of course. Less patients overall, not because they're necessarily less sick, but they do not have the funds to pay for transportation, which is unfortunate, and waiting longer times to get to the clinic. More stress and less joy. These are some of the changes that they're able to see with the data that they're collecting, and more accidents from the displacement. Again, increased depression. Sorry, I jumped ahead here. These are still the changes that they were seeing. More time dedicated to surviving instead of using that time for caring for children. Just to have to make these decisions is so sad. Shorter attention span for listening to health education. They're distracted because of the trauma that they've experienced. Less trust in the healthcare system. Decreased access to clean water. Of course, we saw that with the cholera outbreak that's been going on. So here's some of the data, and Real Hope for Haiti has been functioning since, I don't know if they were before this, but they've been collecting this data since 1998. And you can see once they open their programs, these lighter colors are lower percentages of children who were malnourished that were coming into the clinic, which is fantastic. But then you see here, starting in August of 2022, when really things started getting out of control in the area, that there has been an increase of malnutrition in the area, which is incredibly unfortunate, but also a true reality for so many in Haiti right now. This is average malnutrition rates from 1998 until today. So you can see we're back on the rise here as well. So I am going to stop sharing my screen. This is not quite the end here. I would love to pass it over to Chris, who is with Meds and Food for Kids and is part of the solution. You've been referred to multiple times already by our presenters, and we would just love to hear about what you're doing and how people can access your product, how transportation is working, and what other options there are, and really just to hear from you, Chris. So I'll hand it over to you.
Absolutely. Well, thank you, Rachel. And it's so good to see everyone on this call. I know you guys are each doing just amazing work through Haiti and during a time where we need it most. So really applaud all the work everyone's doing. For Meds and Food for Kids, let me give you just a little kind of insight to what the last few months have looked like, and then maybe what we can expect in the coming months. So as we all know, the end of last year, we saw a lot of unrest in Haiti, and the ports shut down for a period of time. And really what happened for us is during the time that the ports were closed, we were unable to get in raw materials, and yet the need was very present. And so it exhausted all of the supplies that we had, all of the supplies that MSPP had and that UNICEF had in reserve. So ports opened back up, and just the nature of the beast in Haiti, it took a little while even after that before we were really able to get things going again. And once we did, we had just everything we could make was going to UNICEF, and then from UNICEF to MSPP. And so I think probably some of you may have experienced some shortages or some difficulty getting product from us, probably in December or January. But I'm happy to say that now I think we're completely over that gap. And what we're seeing in our dialogues with UNICEF, and this is both with UNICEF Supply Division, which is based in Copenhagen, and then UNICEF Haiti Country Office, they have the largest amount of funding they have ever had for plumping nut, for Medicamamba. And so UNICEF is really, they are issuing purchase orders for product in a way that we've never seen before. What that should mean for all of you is, specifically those of you that are registered with the MSPP, is that going forward, you should not be running into issues of lack of product at an MSPP depot. Now, I know it's easier to say that than the reality of the day-to-day. But to give you some insight into what we're doing, we deliver product to UNICEF directly in Port-au-Prince, who then distributes that product in the Port-au-Prince region, and I think everywhere south of Port-au-Prince. On behalf of UNICEF, we deliver product directly to MSPP depots in Hinche, which is Central Plateau, in Cap-Haïtien for the north, Fort Liberty for the northeast, Port-au-Paix for the northwest, and then Gonaïves for Artibonite. So those depots, we have very close communication with them now. And when they are out of product, typically we are notified immediately. And most of the time we're trying now to get them product before they would exhaust their current supply. On our side, we're producing between 10 and 20,000 boxes of plumping nut a month. And all of that product right now is dedicated for Haiti. So if you're not registered with MSPP and you need product, please feel free to reach out to myself. I'm happy to provide my contact information to Rachel, and you guys can distribute it. You can contact me directly. I'll also provide the contact information for our customer service manager in Haiti, as well as for our founder, Dr. Patricia Wolf, who's been doing malnutrition work in Haiti for 30 years now. So feel free to reach out to us. We will do everything we can to help you find a way to get product or make product available. And for those of you, you know, Rasha, Amy, Lindsay, anyone who's getting product from MSPP, if you do run into issues of product shortages, please let me know. And what I will be happy to do is, how can I say, very appropriately convey information of shortages to UNICEF, which may help them in their logistics planning for MSPP. Because we shouldn't, going forward, we should have more product available than MSPP is able to distribute right now, just because of the need that's there and the, you know, the locations that are available. So I'm trying to think if there was anything, Rachel or anyone, if you guys have any questions, I'm happy to answer, but that's kind of an overview of the last few months and then what we kind of expect going forward.
Can you talk just a little bit about what the product actually is? We're sort of presenting under the assumption that Medica Mamba or Plumpy Nut is a familiar product, but would you just share a little bit about what it is and how it's made in Haiti and all that?
Absolutely. So we make predominantly 3 products in Haiti. We make Medica Mamba, which is also known as Plumpy Nut, which is for severe acute malnutrition. We also make Plumpy Sup and Plumpy Dose, which are really the same product. One is just in a 100-gram sachet and the other one is in a 50-gram. And those are used for moderate malnutrition as well as prenatal treatment. And we make Vita Mamba, which is a nutritious school snack, which we deliver to schools throughout the country and through partnership with BND to Haitian schools throughout the country. So, and that's really about, all of these are nutritionally fortified supplements. So the Plumpy Nut, which is the one that we're talking about the most in this call today, yes, thank you, Lindsay, is, you know, at risk of telling you information you already know, it has a 2-year shelf life. The amazing thing about it is it doesn't have to be refrigerated, so it holds up very well in the harsh climate of Haiti. And it is a standalone treatment, so you can provide that supplement to a child and that supplement only, and take them from a severely malnourished little baby into a healthy little human being. So it's really an incredible product. We make it at our factory in Cap Haitian. So to do that, we import raw materials from the US and from Central and South America. We also procure peanuts locally in Haiti to use in the making of that product, though we still have to supplement those with imported peanuts. So that product is made at our factory, where we employ a little over 80 people, and then we distribute it through partnerships with UNICEF and with many of you throughout the country. So what we run into sometimes is challenges with the port. You all are probably familiar with the interesting relationship, the complicated relationship with Haitian customs. That's not always easy to navigate. And unfortunately, during times of unrest, also you can see long delays in the port, which occasionally impact our factory as well. But that's kind of would you like me to go into any more detail, Rachel, on that?
I don't have any other questions, but I will open the floor up if anyone else has questions for you. And there are some questions also in the chat that we can bring up as well. But I'll open it first if anyone has any questions for Chris. And Chris, I'm operating under the assumption that you'll provide information that we can pass out to the network for anyone who's interested in purchasing from you.
Absolutely. Absolutely.
Okay.
I can send that in the chat box.
That would be great. Go ahead, Amy.
Yes, I was looking how to raise my hand. Clearly, I'm not good at this Zoom. Chris, I was just wondering, you might have said this, but do you have Plumpy Sup available currently?
We do not. We may have some Plumpy Dose available right now, but I think almost all of our demand for the moderate malnutrition products has switched over to Plumpy Dose. recently, and that's largely being driven actually by World Food Program. They have switched their procurement from Plumpy Sup to Plumpy Doughs.
Okay. Yeah, I was thinking of a product we could use for prenatal program and the malnutrition we're seeing prenatally, which is why I asked about the Plumpy Sup.
Yes. Well, that Plumpy Doughs, I mean, you have to just give double the quantity, but it is the exact same recipe. So in a pinch, if you needed Plumpy Sup and we don't have it available, Plumpy Doughs would be an option. And I believe it's the same quantity of product and the same price per box. It's just you have double the amount of sachets.
Okay, great.
That's great. Does anyone else have any questions for Chris? I know we're a little bit over time, so some people have had to hop off already. But for anyone who is able to stay, we're happy to have some questions. Okay, I'll go to some in the chat. And Joanne asked a question that this is something we're actually discussing within the network about losing staff, nurses, community health workers, doctors. For those of you who are overseeing facilities, are you coming into this problem where you're losing some of your staff?
We haven't lost anyone yet, but it's definitely a concern. You know, if any of the people working on our team were able to go to the States, I mean, or Canada, we'd be very happy for them. But of course, you know, that we're always trying to be ready to kind of have people in the wings that are being trained, or at least be aware of where we can find replacements in a pinch. But yeah, what we're hearing most is the Canadian work visas, which is has been interesting to a lot of nurses, and I don't know much about it.
We've lost a lot in the we lost probably around 8 of our staff, 3 in the management team, so a little bit harder to replace management. Easier to replace doctors, lab techs, nurses. But CAP has become the favorite city for everyone across the country. So a lot of people from Port-au-Prince are applying, from Artibonite, from the south. So finding management will not be that hard.
I have actually heard that for those who are outside of the city, how they're losing, but also there are people coming out that way, which is helpful. But we did hear some reports from hospitals in Port-au-Prince who had lost huge percentages of their staff, which is a major, major concern. And of course, it takes many years to build up a staff and build a health system, and then to lose so many at once is definitely could be decades to rebuild that. So we know that that's an issue. Belinda, oh, sorry, I thought you had your hand up, but that was my mouse. Does anyone else have any other questions before we close here? And just so everyone knows, we will definitely send out a follow-up email with lots of information. We do have more slides, more handouts that I will include that in. Some of them were how to make some supplements if you're out of what you can purchase, which is always helpful as well. So that will be coming your way. Stay tuned to the emails for that. But I'll just, if anyone has any last comments or questions. Oh, I see a message in here. Are MNP supplies available? Priscilla is asking. I'm not sure what an MNP supplies are. You are on mute, Priscilla, if you want to unmute.
Micronutrient powders for mothers or caregivers to fortify food for the family at home. In point of consumption food fortification. Are people promoting that or doing that? Are the supplies available?
Great question. Does anyone have answers to that?
Yeah, I do not. You know,
No.
it would be something, Priscilla, I can check with Dr. Wolf. And she may have some ideas about where to source that, but I'm not aware of any.
Right. I bring it up because that's something we promote, and we're trying to get a scheme going where people can order it from India to be used in places like Haiti that definitely need it. It's something that has become very a big part of a lot of nutrition programs, and more on the preventive level for hidden hunger, for adolescents, for children, adolescents, women in childbearing years. So it's very important, and we're trying to find a way. It's always hard for people to get their hands on this. We're trying to find a way to facilitate getting it out of India. If there'd be interest, we could send that around to people in the network.
I do know that I've heard of people using things like moringa, drying it up, and putting it into a powder, and then also using that as a supplement. It's a plant.
Right. That's actually a very good alternative if you can't get a full, balanced, scientifically based formula. That moringa powder is a valuable thing to do.
So they can grow that here in Haiti, and I know of multiple people that actually do dry that out, put it in a powder, and use that as a supplement. So again, it's not like a total thing. Maybe Second Mile does a lot of those things. Also, I've also heard of, and I don't know if this is the English word, but there's a fruit or a vegetable called lamb. I don't know what it is in English. Sorry.
No. Is that breadfruit?
But people also dry that out and put that in a powder and use that as a supplement as well. So I think that there are some more like natural types of remedies that people are using that are available here in Haiti, but it's not like a product that's being produced and being sold, so to speak. But I know that a lot of, people in community have become creative with what is actually available here to be able to help fortify the diet. And those two things are things that we've used and have friends that use as well.
Right. Yeah, we'd be interested in knowing if people are interested in exploring it, because we're pushing it. We've been using it in our own nutrition programs, but it's getting hard to get it. And so we've got some people in India who are willing to produce and take orders. So if there'd be interest in that. Also, they can be used to fortify homemade, ready-to-use therapeutic food that people can make on a village level. Not to compete with Chris, but when the supply chains are broken, it could be helpful for people to have the ability to make it in their own community.
I think one of our main barriers to bringing things into the country is customs, and the challenges we're facing in the airport or at the ports, and just the difficulty of getting stuff out. So yeah, I mean, happy to hear solutions or workarounds, but as much as I want to say, yes, I'm interested, we'll take a billion pieces, that would be a nightmare to take a huge amount and then be charged thousands of dollars beyond what we've had budgeted.
Yeah.
Absolutely. I will say we've had a lot more luck going through Cap Haitian than we have in Port-au-Prince. Port-au-Prince has been excessively difficult the last 6 months, I would say. Where Cap Haitian has been quick. I won't say easy and I won't say painless, but compared to Port-au-Prince, it was a cakewalk. So we'll
Are there any NGOs that have ways to get things through into the airports and through?
I think, and this is my experience, everyone is having issues at this point.
Hypothetically, if you have a franchise, you can get things in easier, but even those that have franchises are having difficulties getting things in. So it's a challenge.
Yeah. Absolutely.
I did just want to address something that came up in the chat too, Rachel, if that's okay. Lori's question about the F75, F100. I know that for us, that's a therapeutic milk. It's like a formula, but we don't like to call it formula because it's not the same thing as formula, that we use in our inpatient facility to help treat severe malnutrition. We get some of that from MSPP, so I'm not sure, which I know that they don't always have that as well. So I'm not sure the same agreement if they get that from UNICEF, like they also get the Plumpy Nut. But I would definitely be checking with MSPP before you purchase it. But I do know that even when we go to try to purchase it, sometimes it's there's a very low supply. I don't know if you use it, Amy, or not, but it is very hard to get. But we also make our own. And so that's something that Rachel brought up. There's a formula that MSPP actually gives out. I don't have it with me right now, but it's a mixture of a lot of things that can supplement, or I don't want to say replace 100%, that can be used like F75, F100 as well.
Can I say you can also get some recipes through the World Health Organization, the pocketbook for hospital care of sick children. In the section on malnutrition, there's a lot of good recipes that you can use in inpatient units for F75 and F100.
Okay, great. So thank you. There's lots going on in the chat. I'm going to save the chat and might be connecting a few of you so you can do some follow-up, or we can see if we can do some Haiti Health Network networking and doing things together in that way as well. So thank you so much, Rasha, Amy, Lindsay, Chris, for sharing. Thank you everyone for being here. Hopefully this was informative for all of us, and just want to encourage you to keep doing the work that you're doing. It is vitally important. Haitians are truly suffering, and just so thankful for the work that each of you are doing. So keep it up, and I will be sending out an email with follow-up, and hopefully we can get some more nutrition happening. So thank you everyone, and I hope you all have a wonderful rest of your day.
Thanks.
Thank you.
Thanks, everybody.